This tool is one of several resources available for children and young people's mental health commissioners and is supported by NHS England's Mental Health Clinical Policy and Strategy team. You can request information on the wider Commissioner Support Programme via the email address displayed on the screen here. In 2015, NHS England commissioned SCW, NECS and Healthcare Decisions to develop a strategic dynamic modelling tool. The aim of the tool was to test underpinning commissioning and service model assumptions, support commissioners and providers to articulate their shared aims, and to present a strategic vision for the future of services. During 2017 and 18, engagement exercises were carried out in 10 regions. Modelling was undertaken by commissioners and providers to support planning in their community services and support them to test local assumptions. So why use this tool, or indeed a modelling tool at all? Well, it allows us to review current services to understand why the waiting list is such a challenge, or what happens to our system if we close that bed. It enables us to plan for the future by looking at hypothetical changes to our services in the region. It supports collaborative discussions with providers, truly understanding openly the impact of an investment or indeed a disinvestment. It means we can work together in our system to start to understand how we can achieve the policy targets. The range of organisations and individuals involved demonstrates that this was very much a collaborative piece of work. But perhaps most assuring for those of you who may well decide to utilise the tool, this has been built based on evidence. The information and techniques draw in both academic knowledge and research, alongside industry expertise, meaning what you will see will truly talk to you, your systems and your challenges, and hopefully help you to work through them. So why do we need a tool at all? The problem we have is that we don't know how many patients are going to come through the door and how demand will change in flux. It's predictable and unpredictable all at the same time. We have to be able to manage that uncertainty. The same problem came about in the 1920s and was resolved with the introduction of the telephone exchange. You don't know when people are going to call, you don't know how long they're going to stay on the line for. So how can you ensure your network is available 99% of the time without unlimited resources? Agner Erlang solved this problem utilizing what we now refer to as queuing theory. Queuing theory is now widely used by the telecoms industry as well as many other industries such as the military, traffic management, and airlines. Queuing models analyze how people receive a service by considering the arrival process, how they arrive to that queue, how people behave in the queue, how long they will wait, for example, the service discipline, the length of time people are in a service, the number of practitioners available, whether people are seen in groups or one-to-one, and how the next person to be seen is selected, waiting room, the numbers allowed to be waiting in the queue. Let's see an example. We have 500 people in our queue. The period of care is normally between 6 and 7 appointments, and I want no one in my queue waiting for longer than a locally defined target of 12 weeks. Finally, I also want to ensure all my patients are seen in the region. The queuing theory principle can help you turn that data into tangible intelligence. It can help articulate how many appointments per week you need to provide or how much that service will cost to run. You can see here that the queuing theory principle can help you turn that data into tangible intelligence. It can help articulate how many appointments per week you need to provide or how much that service will cost to run. Using that sort of basic information and those principles and aspirations, the data can then be extracted and graphically represented to easily understand things such as the impact in utilization of appointments, the impact on waiting times by adjusting appointments per week, how costs will increase as case numbers increase, and much more. Let's look at a practical example for an inpatient unit where we have mapped the data into a curve. The graph shows waiting times in days on the vertical axis and the number of beds on the horizontal axis, and we have a curve showing the length of stay as approximately 60 days. We can see that the service operating with an average of 60-day length of stay and 12 beds has an average waiting time of less than 10 days. If we now consider this unit with one less bed, we can see that the waiting time increases, but is still less than 20 days. If we pull out one further bed, we can see that the waiting time no longer even registers. Our system has become unstable. Finally, here are some testimonials from colleagues across the NHS who have been involved in modelling using the SDMT. To gain access to the tool, please visit cypmh.scwcsu.nhs.uk, where you will find resources and materials to help get you up and running with the tool, along with a range of video tutorials. The video titled Introduction to the Tool will provide you with all the information you need to gain access to the tool and take your first steps. If you have any questions, please do get in touch with our support team at cypmh.model@nhs.net.